Hoffman has emphasized the point that the practice of doing multiple C-spine X-ray puts patients at risk. He conducted a prospective study where he created the National Emergency X-ray Radiography Utilization Study. This study was designed to address the problem of past criteria that is used to reduce the risk of trauma patients. It was designed to define sensitivity for detecting significant C-spine injuries of X-rays done. Nexus is used to determine the reliability to identify patients who have no risk of C-spine injuries and can be spared of radiographs that are not needed. Radiology technicians will be instructed not to perform C-spine injury if they do not get a Nexus form to conduct such examination. Ladies and gentlemen, this is the future of trauma imaging. The variables of my research will be independent, the number of examinations done per patient, dependent, sex, and age. I decided the best way to answer this research question would be by conducting a retrospective study, like some of the past research of past medical records that would entail cases and control of blunt trauma patients. Cases would include radiographs of blunt trauma, and control would include radiographs from all other injuries done in the same examination. For my population and sampling, what I did to gain my sample size was that I needed to know the population of Region 3, where the West Delaware Hospital is located. According to the Bureau of Statistics, 1,787 persons reside in Region 3. I then used this population size along with a confidence level of 95% and a margin of error of 5 on this table to obtain the sample size. The size was too large, so therefore I put the results into sample size calculator with the same population of Region 3, the 95% confidence level, but an increased margin of error of 16, where I got 36. I accepted this because of my large population and therefore with a large margin of error. Random sampling will be done in this research of 72 cases, meaning that 36 will be control and 36 will be case each, making 7 cases and control for each consecutive year. Data will be analyzed with analysis of varying tests. I will calculate the mean, the mode, and the correlation coefficient. My time frame, I took about 4 months to gather the research that I have presented here today, and I will need at least 2 months to putting the actual patient records together. I have gotten informal consent from the West Delaware Hospital and will get formal consent in the near future. My content will take approximately 3 months to analyze and calculate, disproving or proving my hypothesis. Not much research has been specifically done on measuring the amount of radiation taken in emergency cases of blunt trauma. Researchers tend to focus on all forms of trauma, and every researcher has their own meaning of what they call a protocol that is approved. Many of them lean towards the medical aspect, but I will be leaning more towards the radiology aspect because we as radiographers are the ones with the last say in taking the radiograph, and we're the ones that are more trained to take the radiograph, so we know what is best. And I will, of course, carry this investigation to prove my topic that protocol can reduce radiation exposure. I would like to thank my supervisor, my family, God, and you all for listening to me today.
Thank you. And you still have 3 minutes left, but we will go directly into the questions. 5 minutes on the clock. If you could begin. Yes.
Right. So the first question that I have for you is your main source of reference for your level and number of traumas and incidences on its nature. Whether it would have been better to pull an official statistic from the Ministry of Home Affairs, you could go to their website and you'll get that statistic on an annual level, on a quarterly level, and everything. And generally, that's where the newspapers go for their information to make it a little bit more legitimate rather than from a newspaper. The next thing is you mentioned that you're going to be basically getting an idea of quantifying the amount of radiation exposure that is received during trauma series. Will that be classified into what the patient receives, what the occupationally exposed personnel receives, what the doctor receives, or is it going to be a collective sum of what everybody receives?
I want to look exactly at what the patient.
So if you're going to be measuring how much radiation the patient receives, should you have some sort of method directed towards quantifying the amount of radiation they receive for a series of examinations or something like that?
What I will do is that I will the literally amount of x-rays that are taken.
Each X-ray examination is a different exposure factor,
Yes.
dependent on the area that is going to be examined. So you wouldn't be able to say if there were 5 X-rays done, it's going to be 5 times 1 standard quantity of radiation. So how do you plan to quantify the amount of radiation the patient receives during that? Because that's what you said in your objective.
There is a chart. We have an extra chart. Every exam that they take, they base it on the chart.
The technique chart is used as a baseline, but it's obviously adjusted based on the technologist's idea of whether the patient needs more or less. So you're going to be basing it on the technique chart, that's what you're saying?
They go directly to the chart.
So my argument is not on whether they go directly to the technique chart or not. My question to you is, will you be basing your quantity of radiation that the patient receives during a trauma series on the technique chart?
Yes, your answer is yes. All right, let's move
But
on.
you know that has a lot of errors in it because it's going to vary from patient to patient. What is the involvement of the risk-benefit ratio in determining what form of ionizing radiation to use and how many to use?
In terms of the
Because I didn't hear any mention of that, and that's one of the important tools that is normally used to determine whether the trauma patient should be subjected to that amount of exposure. You mentioned that the radiography is the last thing to say, which at least I know in some cases in our hospital, if the GMO is unsure about whether they should order all of it or just some of it, or there's another type of examination that will cover the area of interest that they need, they ask because the risk-benefit ratio is what comes into play there. I didn't hear anything about the risk-benefit ratios mentioned. Is that going to be considered?
Yes, that will be considered.
From how and whom and what?
It will be considered from the person, the occupational exposed personnel. When the patient comes into the department, especially at that hospital I'm looking at, the doctors, they write all sorts of things. But the technician, they don't take into consideration that they should weigh these options. They just do it all like that. They don't weigh the risk and the benefits of it. They just
So shouldn't there be a tool whereby you investigate whether the doctor who has prescribed the examination has used the risk-benefit ratio? Shouldn't you have like a questionnaire or something of the sort where you evaluate what they consider before they prescribe a trauma series?
All right, let me intervene. Let me intervene here. I think what you need to do is to circumscribe the scope. In other words, this is actually beyond the scope of your research. So you only have 3 months to do this, and therefore what you're doing is a quantitative, as much as possible, quantitative study, which means you're just going to do a retrospective study of previous data. So you need to stay there. And that means that using techniques charts, although it gives you an imprecise measure of radiation, and because you're only using X-rays, it's a specific kind of radiation, that is the limitation of the study. So you need to say this is a limitation of the study, and this is the scope of the study.
So one last question. Do you have any statistical idea of the number of CT exams ordered locally? Because you mentioned a lot of that in the literature review, and we do know that CT is not publicly required. So in most cases, for a CT exam to be ordered, it's actually quite weighted on whether it's needed or not, because the patient has to pay, if not full price, half the price in case of BPHC. So would it be useful to you to investigate exactly how many CT examinations were actually ordered? And probably guide your sample size towards that direction.
I mentioned CP and potential review because CP was what is done, but my methodology is not CP. So I wouldn't.
But you extensively reviewed on.
Okay,
But I
so
wasn't
thank you
able
very
to
much. Your
see
time is up. So you do need to say that you are limiting the scope to X-rays, and therefore CTs are not going to be included. Thank you very much. I'm going to let you answer questions afterwards and by email.